गुड डे। कैसे हैं आप सब लोग? ड्रेन्स के बारे में this session. There was a question on drain. It is very obvious the pattern of questions are very much clinically oriented. Now, if you had seen this drain even once in your clinical posting, you will remember it with for life. So being invested in the clinical space is very, very essential, more so now that next is going to be in the picture. So what was given was this image. This image was given and the name was asked. You have the various options here. Now for me to just go to the right answer and tell you what it is, it's not going to help you. So I thought I'll take you a little bit into the different types of the drainage systems. What are the clinical scenarios where you will use which drain and ultimately make the right answer. And all these images are in this presentation are from my personal collection. You can see the same drain here. You see, when you see it as a photograph in isolation, everything will be clear about it. But when you see it in a clinical setting, you may not be able to see all the details. And personally, I feel an image or device or an instrument should always be projected while in use on the patient for better conceptualization and hence comprehension. So these online sessions are only to facilitate and support your clinical skills. It is not a surrogate for real-time patient encounter. And the same image may be being repeated many times, and patients have given consent for their images to be used. So what is the function of a drain? It is to remove the unwanted and help in resolution of the process. Drain may be the first indicator that an untoward process is happening. Like in your thyroid, drains may have blood. You know there is a bleeding going on in the post-operative period. Or a case of intestinal anastomosis resection. In the drain, you find very thin fecal matter. You know there is an impending fecal fistula. There is a fecal peritonitis. So it may be the first indicator also to tell you that some things are going terribly wrong in the deep space. Now, how do you classify drains? What I find students most of the time, they mix up this with this part. A classification can be based on many things. If you understand what it's based on, then you will not go wrong. Because an open drain may be any of these materials. If you understand that, there'll be no confusion in crossover. So classification may be based on the mechanics. It's an open drain. It can be closed with a suction, or it can be an underwater seal, which is a type of closed. The material used could be red rubber, a simple plastic, latex, PVC, or even a silicone. And now when you use internal drains, like you're draining the hepatic ducts, you can use biodegradable so that you need not again do another endoscopy and remove it. So now please don't rush through the images. Stay with me. I'll take you there in a very systematic way. So what about these open drains? You can see the drain here. It's kept for large superficial contaminated wound. This was a road traffic accident, very bad wound, lot of contamination. You keep a drain, whatever infective material gathers at the depth will come out and it will allow healing. Now, the disadvantage is if this is kept inside a cavity, this open drain is kept inside a cavity, it will take the infection from outside also. What about closed drains? Drain collection involving a cavity or in the peritoneal cavity. You see, this is a peritoneal cavity. This drain is going into the peritoneal cavity and it will only take out the material from inside and leave it out. So outside organisms will not get in. So this is the difference between closed and open, and this system is sterile. Naturally, it is sterile. What about closed suction? Suppose you want a sterile closed thing, but you also want to give some negative suction so that more of this unwanted stuff will come out. It will be aided by the negative suction. So you can do it provided it's not inside a cavity like your thorax or the peritoneum. This is a psoas abscess. Psoas abscess will get walled off. It will not communicate to the peritoneal cavity, and you can put a bromovac drain. This is closed and also it gives some suction. There is better drainage rather than just plain closed drainage. Now, what exactly a vac means? A vac means you give more suction than this. This suction will be maximum 60 to 80 millimeters of mercury negative suction. But this can give up to 120. I've made a presentation only on vac. It is there in the playlist, in the recall playlist. Now there's something known as an underwater seal. So this is also closed, but it is under the water. Forget about this, the urinary catheter. This is an underwater seal. This is an ICD draining a hemothorax, but it is an underwater seal. You can see the column there. And this is the water which has got mixed to the blood. So this is the column. You will keep it in an underwater seal because you don't want atmospheric air to run into the chest cavity. So you use it for hemothorax, hydrothorax and pneumothorax. This suction drain, again I'll be taking you through some other scenarios where you will be using suction drain, like your post-thyroid surgery or your incisional hernia surgery. These are the common, and breast. So coming to the material used, you can have red rubber. I told you red rubber. Look at the red rubber here. You can see the red rubber drain. And if you look at it, this patient has two different types of materials and two different types of drainage systems. One is your open drain. One is your closed drain. This is a red rubber and this is a polyvinyl chloride. We are not going to go into why he needed these two, but you can make out that the same patient at the same time needed two types of drainage systems. Coming to a simple plastic, a Rice tube is also a type of drainage and it is made of simple plastic. Let's look at polyvinyl chloride, that is your intercostal tube. I don't have a silicone tube in my personal collection, or could not find it. The latest is the biodegradable drains. Now suppose you want to put an internal drain. This is your biliary tree and this is your duodenum. For some reason you wanted to stent this area. There is a stricture there or whatever. There is an injury, whatever. You want to put a stent right from the right hepatic and take it into the duodenum. In that case, this tube has to be removed. You have to do an endoscopy, picture the duodenum, come out and then remove this after its work is over. But if you put a biodegradable one, it will degrade and get absorbed the moment its work is over. Now coming to the materials, which is the most reactive, you can see the slide, you can see this diagram. So the most reactive is your red rubber tube and the least reactive will be your biodegradable. Now in a drain, look at the color of the effluent and look at the quantity of the drain. Now why quantity? In bleeding, you'll know how much he has bled. You will know how to replace, or how much of bile is coming out so that I replace those electrolytes and water deficits. That is the idea of looking at the quantity. Coming to color, you can have frank pus. You can see this pus. This is peritonitis, frank pus. You can see this is a liver abscess which has ruptured into the peritoneum. And there is peritonitis. You can see frank pus. And you can also see the amount. It is about a liter. You know this patient is in severe sepsis by just looking at the drain, let alone looking at the vitals and the other markers for sepsis. Then you can see blood. This is a hemothorax. It's altered blood. Now in this, you found out the color. It is altered blood. And number two, you know it is an underwater seal. This is bile. You can see the yellow color. This is bile leak. We are not going into the exact details of the underlying pathology. Look at this, straight away feces. After a laparotomy, you have feces draining through the tube which is in the peritoneum. This is very, very rare. I wanted to share. This is mucin which started coming out after we have operated for a pseudomyxoma peritonei. So this is very, very rare. You can just keep it in your mind for interest sake. But the most common will be pus, then blood, then bile and feces. Now, don't rush into the images. I will take you there. What are the complications of drain? They can get blocked. These drains, especially the closed ones, can get blocked. Have a look. They can get blocked. They can be left for too long. Either patient didn't come for follow-up or for some reason. There can be injury to other structures. Drains can break in between. There can be retained drains, especially when it breaks, it will remain back in the place where it was put. Now have a look about injury to other structures. This is a Ryle's tube. Patient has had a Ryle's tube removed, but you can see that there is a necrosis of the nasal cartilage. You see this blackish area? And this was sent by my professor. This urethral catheter was left for too long, either because of neglect or patient socioeconomic problems. This catheter was left for a long so that the whole of the urethra, that is the ventral part of the urethra itself, has got necrosed. This is very important. So it has got necrosed. Now coming to uses, I told you, you will drain it to see pus, blood, everything, or your pleural cavity. Even in large contaminated wounds, you can use them so that necrotic material doesn't get accumulated in the bed and impinge on healing. After mastectomy, these are classic examples. After mastectomy and axillary dissection. This patient only had an axillary dissection at this point of time. We'll not go into further details, but you can see we have put a drain and connected to suction because these flaps, this axilla is full of fat and you have raised skin flaps. They'll keep on oozing seroma. That should not accumulate and get infected. Similarly, if you have operated on the breast, even if it's a conservative surgery on the breast, there will be leakage of seroma under the flaps. Or after a BK amputation under the flaps. This is the anterior flap. This is the posterior flap. And the flap will have muscle. There will be actually oozing of serous fluid. That should not get accumulated under the flap because it will raise and open off the flap. So you have a closed drainage here. So these are the common conditions where you put your drain. So the drains, if you look at it from the undergraduate level, after mastectomy and axillary dissection, after thyroid surgery, and after amputations. So now coming to the question, it was a named this device. Let's go through options. Is it a simple closed drainage system? No, it is a closed drainage system, but it is not simple. You have seen these simple ones. Is it a closed suction drain? Yes, it is a closed suction drain because you can press this and it will give a negative suction. Is it a vacuum assisted drainage system? No, it is not vacuum assisted drainage because if it is, the tube will be connected to a device. The tube will be connected to a device where you can adjust the pressure. It is not a vacuum assisted device. Is it an underwater seal? No, definitely this is not an underwater seal. So the answer is a closed suction drain, and these are known as Romovacs. They are known as Romovacs. It's made by the Ronson's company. So you can call it Romovac, but the scientific term is a closed suction drainage. So I hope I have made I've given you some clarity on drains, because next year another question will come on drain. That time they'll put an open drain or they will change the material in the drain. There are only two things in a drain. One, the functions. Two, the complications. Number three, the mechanics. And number four, the material used. So the most complicated one will be the mechanics. Otherwise, there is nothing much to learn in a drain. They will keep on harping on the mechanics of the drain. So if you know the classification is based on mechanics and the material use and a few about the complications, and there is only two uses of a drain, you will be well settled to answer that MCQ. Thank you very much.